Hello and welcome everyone to our second webinar on suicide prevention in a time of COVID-19. So just to introduce myself, my name is Tom Ayres. I'm the Director for the National Collaborating Centre for Mental Health at the Royal College of Psychiatrists, and we're really pleased to be running this series of webinars, of which this is the second, with the National Confidential Inquiry for Suicide in Manchester. We are joined today again by three panelists, so I'm going to introduce those the three panelists now, and then I'll talk about the agenda and how we'll run the session before we get into actually the discussion. So our first panelist is Professor Louis Appleby. Louis will be familiar to, I'm sure, many people on the webinar who are watching. He's Professor of Psychiatry at the University of Manchester and also Director of the National Confidential Inquiry into Suicide and Safety in Mental Health. He also leads the National Suicide Prevention Strategy for England. He's been working with NHS England, Public Health England and other academics to form a national academic response to the suicide prevention during COVID-19. Our second panelist, who I'm really pleased to be able to I'm really pleased is able to join us today, is Dr. Ananta Dave. Ananta is the Medical Director for Lincolnshire Partnership Trust. She's also a Fellow of the Royal College of Psychiatrists. In her role as Medical Director, she's the Executive Lead for Suicide Prevention at the Trust and also has a leadership role at system level across Lincolnshire on suicide prevention. Within her role in the college, she recently authored a key college report about the impact on BAME staff or staff from BAME communities of COVID-19, which I really recommend everyone takes a chance to look at if they haven't done already. And she also did a Churchill Fellowship on preventing suicide in doctors and has a role in the Wellbeing Committee of the Royal College. So welcome, Ananta, for your many hats. And our third panellist is Professor Nav Kapur. Nav is the Head of Suicide Research at NKISH. He works with Louis at the National Confidential Inquiry, and he's also an honorary consultant psychiatrist at Greater Manchester Mental Health Trust. He's led various committees for NICE on self-harm and suicide prevention, and also sits on the National Suicide Prevention Strategy Advisory Group. I should say at this point that Nav is not quite with us yet. He's struggling with Teams to get onto the webinar, but we hope he will be joining us soon, and one way or another, so that's something we're just working on behind the scenes. Okay, for our agenda today, if people dialed into the previous webinar, they will be familiar with the format, which is I will stop talking very shortly about in terms of the welcome introductions and hand over to Louis, who will tell us what the latest early data says so far about suicide and COVID-19. We've then got three sections of three questions in the agenda, each of which will form a section of about 15 minutes. And those sections are where we want to open up to questions from all of you watching. We will I will talk a bit about the Q&A format in a moment, but that will be hopefully quite a discursive section, and then I'll wrap up with concluding comments at the end. So the three sections, I assume people can see it, but first of all, we'll talk about managing the mental health of healthcare workers. Then we'll talk about what we know about COVID-19 and suicide prevention in Black, Asian, minority ethnic groups. And then finally, we'll talk about how mental health services are adapting during COVID-19. So just to go quickly over housekeeping before I hand over to Louis. So the way that the webinar works is that this is a live event, and therefore the only people who are able to speak on it are the presenters, so myself and the three panelists who I've just introduced. So if you're watching, I'm afraid you won't be able to speak on the webinar, but we do have the Q&A function that you should be able to access on your screens to ask any questions that you would like to be answered. There'll be a Q&A section, Q&A throughout the webinar, and I'll be trying to summarise the questions. In the previous webinar, we had about 80 or so questions, so obviously not the number of questions we could go through in the hour or 45 minutes or so. Hopefully we get lots of questions today, but please keep asking them. We will try to answer the best we can. We will, following the webinar, again look to collate the questions and post written answers. For people who joined our first webinar, you may be wondering where the written answers are that we talked about at that time. As I said, there were a lot of questions to answer, and the team at NKish have been working through them, and they should be posted live on our website in the next few days or next week. And again, it will take a little bit of time to get the Q&As up from this webinar as well. Please bear with us for that. And finally, the webinar will be recorded, and we will share the link on Twitter and social media, but it will be at the same. It will be hosted in the same place as the invite for this webinar, or the link to join this webinar. It usually takes a day or two to get posted on the website, so if you keep your eyes posted for that. So without further ado, I'm going to hand over to Louis now, who will talk us through the latest that we know about data and suicide prevention and COVID-19. So I'll hand over to you, Louis.
Well, good morning, everybody. Thank you very much, Tom. I hope everyone out there is well, looking after your own emotional health. We thought we'd start today with a word about data. It's an important part of the national response on suicide prevention to have up-to-the-minute data so that we can monitor what happens, monitor change, understand who's being affected. And for that reason, we've had to set up new data systems. We're in the process still of setting up those new systems for what's called in the jargon real-time surveillance. So you will know that normally when we collect suicide data, it's based on what happens at coroner's inquests. That's where a suicide is determined. But inquests take a few months, and in fact, the average time to inquest is about 6 months. That's not nearly soon enough for our current purpose. And so for that reason, we've had to develop real-time surveillance, and that's very nearly ready. First of all, for the general population. Secondly, for mental health patients. And thirdly, for children. So soon we should have real-time data on those three groups. I should say I'm not aware that any country has yet got reliable real-time data. So what do we have? I thought I'd just show you a few slides of the kind of thing that we can draw on. First slide now on the screen, I trust. This is a very interesting, very carefully conducted survey taking place based at UCL in London, and it's a general population survey about health, about well-being, about mental health, and it's conducted on a large general population sample, about 80,000 people, who are representative of the population as a whole. It's not a random sample. That's much more difficult to do, but they are at least representative. So that gives us an idea. If you repeatedly sample those people over time, it gives you an idea of what might be changing for people. So here's just one slide. This is publicly available data on the UCL Social Survey website, and this is the part of their survey that deals with population self-harm rates. So people are filling in forms regularly, and they're being asked, have you self-harmed in the last week? And here's what they're telling us. So if you look at there are quite a few graphs in on the website. Look at the top left of the slides that are on the screen. So this is what people say, and you can see overall that's showing no change during the lockdown period in reported self-harm in this survey. The three lines are different age groups, and so the top line, which is the youngest group, has the highest rate. I suppose you would expect that in any self-harm data, and the figures are a little bit volatile, quite a lot of ups and downs, but overall there is no trend, no upward trend, no downward trend, and so we can say from this survey that self-harm does not appear to have increased during the lockdown period. Alongside that, we have some other data unpublished based on hospital attendance with self-harm. So you may know that we collect data in several hospitals around the country. People who come to hospital with self-harm, we collect quite a lot of data about them. And the notification of that information has been brought forward to give us something approaching real time, so that we know from the hospital data that hospital attendances too have not gone up with self-harm. In fact, hospital attendances have gone down. I don't believe that's because self-harm has gone down. It's probably reflecting a change in help seeking, where people are reluctant to seek acute healthcare, not just in mental health, but elsewhere too, and therefore are not attending when maybe they should, but no rise. And alongside that, we have reports from frontline charities telling us about the calls they're receiving, and they are reporting more calls, at least not all, but several of them are reporting more calls from people in crisis talking about self-harm, and they're worried about the level of distress that they're seeing in some of these calls. And if you put some of that together, it suggests that there hasn't been a rise in self-harm, but people who are distressed are not seeking help through hospital as much. They are, however, looking for alternatives through the third sector. Next slide, please. From the same survey, this is everyone being asked a different question, which is about whether they are stressed by the COVID situation. And you can see that the first thing that this tells you is that most of these lines are going down. So most people who are answering this question are saying that over time, they're becoming less stressed. But if you look at the bottom right graph, the difference between these two lines is people with a mental health diagnosis and those without. People with a mental health diagnosis are saying they are more stressed, more likely to be stressed at least, by the COVID situation. And although the figures are improving, they've stayed steadily above the rest of the population. So we need to be aware that patient groups are more affected. Next slide, please. This is a different kind of survey. This is quite a clever study done by colleagues in Bristol, D. Knipe and others in Bristol. And they've gone to Google search data, again, publicly available, and they've looked at the kind of mental health topics that people search on. And so if you look at the top left, that's some of the mental health topics in the UK, and the lines are showing different topics over time, preceding the COVID crisis, during it, and then right up to the minute. And the different dotted lines there are telling at different time points. C, the third of the dotted lines, is when lockdown began. And the suicide topic is the red line. So overall, if you look first of all just at some of the other countries, look after C, so after lockdown, the USA top right, it looks as if they were seeing relatively low levels until lockdown, and then just a slight rising of the searches for, under the heading of suicide. Bottom left is Italy. Again, just a suggestion that relatively low levels up until the time of lockdown, and then the red line starts to go up. And in this country, slightly less data, but again, figures probably not very high. And just a hint after the dotted line C that the red line, suicide searches, has just gone up a little bit. Now, what does that tell us? I think we don't know for certain how that translates into how suicidal people are feeling. It may be more connected with how people are feeling about their mental health generally, but just a warning to us of some of the distress out there. If you're wondering what that big peak is, early in the graph, the big red peak, that was the death of a well-known TV presenter by suicide. Big rise in searches on suicide at that time. And next slide, final slide, please. And then we have a different sort of data entirely. This is actually from the recent Royal College survey published I think 2 weeks ago, I think. And the survey is asking clinicians in different parts of the country what change has there been to their working practice during the COVID period. And the bars there are showing the change towards urgent interventions. So people saying that they've got more work on urgent interventions are the people who are in the blue and orange bars. And you can see that most regions of the country, most of the devolved nations too, have got quite a lot of people saying that's about 43% on average, saying that they've more urgent intervention work to do at the moment. Quite a lot of people saying it hasn't made any difference, that's the grey bars. Some saying that it's gone down. So quite a varied experience, but with quite a few reporting more work. And it fits with what people have often said to me when I've met them, spoken to them, and that is that they feel that clinicians feel that quite a lot of people are coming to mental health care relatively late, possibly putting off help seeking when they should, and therefore more acutely ill when they turn up. And a message to us all there about maintaining contact, making sure we're reaching people who might be vulnerable. So this is the kind of information we have at the moment, a mixed picture of how progress is taking place, how people are feeling, and how services are affected. And over time, we'll have more, and we'll have more specific suicide data too. Thanks.
Thank you, Lewis. That was completely fascinating as always. And so I think that I just wondered, we've had a few questions come in about some of that data, and I wonder if I could just ask some of those questions to you now, if that's okay. So the first, well, there's a couple of questions about that relate to some discussions we had at last webinar actually, which was about self-harm attendances at A&E going down during COVID, and I think your data, I don't know if we're able to get the slide up again, but I think anyway, perhaps that's too complicated, but I think your data suggested that that's true, but and I heard you say that doesn't mean that self-harm has reduced, and I know that Caroline from Harmless was indicating that self-harm had increased in terms of their referrals or people contacting their Harmless. They were seeing an increase during COVID. So I just had a question about the fact that people are not attending A&E as much. Are you concerned? Are we concerned about people's physical health needs being properly assessed along with their psychosocial needs because of that? And is there anything that you think that services should be doing to respond to this?
Yes, so I think the going down of the figures, I think, is probably more about help seeking than it is about the prevalence of self-harm, and it would fit with what Caroline told us last time, but also some other charities telling us too about more call volume. So people perhaps looking for help in a crisis, not necessarily looking for it in through the NHS, through hospitals. I think there's two things. One is that the NHS has realised this, and there's been something of a campaign over the last couple of weeks to say, make sure that you seek help when you need it. You know, the NHS is open for business, physical health as well as mental health. I think there is a real concern that people are delaying, perhaps feeling that they are protecting the NHS. That's after all what they were asked to do. That perhaps feeling that, perhaps worried about whether there are risks of catching the virus in hospital. But very important that people seek the physical health as well as the mental health care that they need. And some people in the mental health care, of course, have both physical and mental health needs, and they need to make sure they're getting the help they need. So there's a strong message there, I think, come from the NHS. I think it's also a local issue. So there's the national message, but I think also the importance of local services making contact with people who they know to be vulnerable. So maintaining that contact with people who might, even if they're not ringing up, not making contact themselves, who might be struggling and who might need additional support.
Okay, thank you. And then just a question about the search, the graphic you showed about searches for different topics, and a question about whether searches on suicide are necessarily a cause for concern. It could be that people are searching for suicide for positive reasons to help others, rather than because they have suicidal thoughts of their own. I just wondered if you had I suppose a general response to that. If we're looking at things like Google Trends, how do we assess, how do we take that data?
I think it's a good point. I tried to say that we don't know what the significance of the figures are. It's an important thing to monitor, in the sense that it's telling us something about what people are thinking about. But it's true that they might be thinking about it because they're concerned about somebody else. It may be that they just simply want to They're thinking about mental health in general, and suicide is an obvious topic. I think the evidence we have on Google Trends is pretty inconclusive about that. It's a relatively early kind of survey, so it's perfectly true. We shouldn't assume that this is an increasingly suicidal population. And in any case, the figures, if that were true, then the figures would seem to be coming down pre-lockdown. And in England, at least, or Britain, at least, they've only increased a little bit. It's not yet, I think, an absolutely convincing rise, as it maybe looks more apparent in the other countries. So I think it's absolutely true. We should be aware of this. We should be aware of what it could mean, but similarly not yet overinterpret.
Okay, thank you, Louis. Okay, so I want to, a final question I'll just answer very quickly about access to the slides for sharing afterwards. So I presume that we can make these slides available, and I think, Louis, you said actually that the data is available in various sources already.
Yes, all these slides are publicly available already from the authors themselves. So the UCL survey is on their social survey website. The Google Trends data is published under the welcome as a preprint. And the college survey is on the college's website.
Thank you, Liz. Okay, so I'm going to move on to the first of our three topics, which is about the mental health of healthcare workers. And we know that there are there's a huge impact on healthcare workers across the country, and some of the sacrifices that they've had to make, but also the huge stress on mental health, on health workers generally. So I'd be really pleased if people ask as many questions as they have on that. But I wonder if I can perhaps, just thinking about some of your previous work, Ananta, if I can perhaps start by asking you to give a couple of thoughts on how we can help manage the mental health of healthcare workers, particularly during this time of COVID.
Thanks, Tom, and hello, everyone. Good morning. I think we've got information through a lot of survey data collected both by individual organizations in health and care, as well as national organizational surveys, professional organizations like the Royal College of Psychiatrists, NHS, various NHS institutions, etc., that a significant proportion of healthcare workers from all backgrounds, doctors, nurses, healthcare assistants, ambulance staff, so all of them have been experiencing increasing stress, and it ranges anything from 25% to 50% of the workforce saying that they have experienced increased stress. And it is we know about the impact of the trauma of looking after people who are very ill, the dilemmas to do with difficult decisions, the loss, the grief, the worry about families, community. So we know all the reasons why healthcare workers might be going through these very difficult emotions and also suffering health problems. So firstly, I think we have to understand that people will require different levels of help, and some of it is about it's not about medicalizing the distress, but understanding that there is the significant level of distress, bereavement, support and counseling needed, and addressing the understandable anxieties and worries, and for some the traumatic reactions. So it's about providing help at a range of levels required, and also in a range of modalities required. We know that for some people, ringing up helplines which are being provided nationally by NHS organizations as well as by trusts. For some people, ringing up helplines feels all right. For some, they would like to have some kind of a face-to-face, perhaps a remote face-to-face consultation. For some, it is a drop-in service which might work. And we know that in some organizations, help is being provided through the local IAPT, the Improving Access to Psychological Therapies work, which already is underway for patients. So I think we need to be flexible about our approach, but key is, I think, the early intervention. But we know that improves outcomes. I mean, as Louise has been talking about it, we don't want to wait for people to seek help till it's very late, till they have suffered distress for a long time, until their health deteriorates. So to be able to intervene early, and I think organizations need to be proactive in offering help, reaching out to those who might be struggling but not able to speak out. So in the report that we did for the Royal College of Psychiatrists as well, what we've said is that it needs to be a whole organizational approach where There is acknowledgement of this issue right from board level leadership, and there is support for line managers and leaders to reach out and have those conversations, sensitive, supportive conversations with staff, and understanding the level of risk that they face and also the impact on their health and well-being. So right from local trust-wide staff support services to more specialist services for those who are severely ill. It's about being proactive, flexible, and intervening early and creating that supportive culture where people feel able to seek help. I think those are the important points. Thanks.
Thank you, Ananta. I'm pleased to say that Nav has managed to join us, although he's dialed in on the phone, so we won't be able to see him on his video, which is a shame for all of us, but at least we'll be able to hear his wisdom and thoughts. So Nav, I just wonder if I could ask you. Hi Nav, I wondered if I could ask you this question, just to follow on from what Ananta was saying, and whether there are any, any best practice that you've heard about in this area.
I suppose, yeah. I mean, it's really important to say, in a sense, healthcare workers have got a kind of, if we're bringing it back specifically to kind of risk and risk of suicide and self-harm, you know, some healthcare workers have got the kind of double whammy, if you like, of both the intrinsic occupational risk, but also the additional risk that results from them being more susceptible to kind of complications of COVID-19. So, in terms of the kind of, if you like, the intrinsic occupational risk, it's, you know, the ONS report from a couple of years ago suggested that female nursing staff were most vulnerable. That report also suggested a 70% increase in risk in suicide in care workers as well. So we need to be aware of the groups that are at higher risk. And from the point of view of kind of specifically suicide prevention, it's something about ensuring that the occupational supports are in place. It's about ensuring that, you know, there's not the stigma around health seeking. I mean, sometimes people are really surprised that, you know, mental health professionals are themselves sometimes reluctant to seek help. So thinking about those, thinking about how, I mean, it's, you know, it's an uncomfortable conversation in many ways when we're talking about suicide, but thinking about, you know, methods and access to methods, and also thinking about how individual deaths are reported in terms of healthcare workers' deaths. I know that, you know, there have been a couple of very distressing reports in the media that people listening in will have seen, and being very mindful about how those are reported, and working with colleagues in the media and with Samaritans to make sure, you know, it's responsible reporting of that kind of event.
Thank you, Nav. And I feel like I wasn't teeing you up with this question, but we've had a question or a comment really about the Greater Manchester Resilience Hub that's been commissioned. I just wondered whether that's something that you're either involved in or aware of.
I'm not heavily involved in it. But you know, initiatives like this, the kind of, you know, more public health initiatives are, you know, really valuable, and there's a number of them around the country that I think you know, are going to play an important role.
Okay, thank you. So that the Manchester hub that we talk about has webinars, guidance, peer support offered along with screening for people, and perhaps we might try and share links to that after the webinar as well. I'm just looking at other questions here. We've got and perhaps back to you, Ananta, just thinking about your previous work on prevention of suicide in doctors. There's a couple of questions about existing higher levels of risk and suicide in healthcare staff, and so they're already kind of I suppose heightened risk amongst healthcare staff. It's known. I just wondered if you had any thoughts on that, and whether there's anything in particular we should be doing around particular groups of staff, maybe.
Yeah, thanks, Tom. We know that, and you know, Louis has been leading work on this about trying to understand the risks, increased or otherwise, to healthcare workers, including doctors, around suicide. And this is pre-COVID as well. And there's been an attempt here as well to collect the data so that we understand whether there is actually an increased risk in absolute terms to doctors and health workers. And we know, for example, there is data about female nurses, for example, having a slightly higher risk compared to the general population about around suicide. But we know that there are several, things around doctors and healthcare workers. The thing about suicide risk in them is that it can take a very long time for them to seek help, and therefore when they do seek help, they could be very ill. So the stigma surrounding help seeking, which might make them more ill and might get them to a stage where they feel suicidal. And secondly, I think is about the impact of that. So when somebody does take their own lives, the impact it has on other people, on colleagues, patients, communities, and how that might actually make people more anxious and worried as well. So I think these are the important things to keep in mind about the risk of suicide in doctors. As Nav was referring to, in respect to COVID specifically, we know that all healthcare workers, from all professional backgrounds and different cultural backgrounds have been facing the stresses related to looking after patients with COVID, and also worried about themselves, their colleagues, their families, friends, and communities. So we know that there is more stress, and perhaps pre-existing mental health problems get amplified, pre-existing inequalities get amplified, and some of them might develop understandable reactions. So we don't know yet about the increased suicide risk due to COVID. As we said, we don't have the data yet. But I think those principles of help seeking in doctors apply. The stigma, the silence, the secrecy is really quite a lot. And I think the perceived impact on one's career, on one's reputation and status is quite high. So I think what we see amongst doctors is that although there might be several positive factors which might might protect them in terms of social networks, perhaps stability of job, safety, etc., but sometimes those can be overtaken or nullified when you look at some of the the impacts, the negative impacts in terms of losing their the fear of losing their license to practice or their status or their inability to work, etc. So I think again, being mindful of having to cut across these the cultures and the fear that has built up of seeking help. And I think a lot of work needs to be done, and perhaps COVID has given us the opportunity, while people are beginning to open up and talk about the potential mental health impacts, the stressful impacts, etc. It's perhaps an opportunity for us to say to everybody, doctors, nurses, and to everybody, it's okay to seek help. Things can change, you can get better, and you can continue working even if you're not well. So although we don't have specific data about COVID, suicide, and BAME doctors, etc., it is an opportunity, I think, for us to talk about the importance of early help seeking, creating those supportive cultures, and looking at the risk factors which might make people more ill, or the risk factors which might prevent people from seeking help. So those inequalities that we talk about that can be amplified might also manifest themselves in terms of people being more afraid to seek help or speak up or ask for help. So I think, we need to be mindful of those issues and make sure that we're addressing those so that problems don't, fester and don't worsen. Thank you.
Thank you, Ananta. And just very quickly, I wonder, just on that issue of stigma and help seeking behaviours in healthcare staff, there's a question here, and I think you will, I'm sure, have heard this in other sources as well, about the idea of an NHS for the NHS, and whether there should be some sort of separate service that healthcare staff might go to, and that might improve the situation. I don't know if you can give a very quick thought on that. Sorry, I was going to ask Louis to just give a quick thought on that, if that's okay.
Yes, well, a couple of years ago I did some work with the GMC about doctors who were at risk of suicide while under investigation, and that was actually one of the recommendations. I mean, we've gone quite a long way towards better support for doctors, I think, than we used to. There's the work that Claire Gerard has been doing to support doctors through her practice, and now the wider support for doctors who might be risk, doctors in the NHS. So that is happening now, but it is just doctors at this stage. And I think some of the other professions are at least as much at risk. I think it's maybe just worth stressing one thing that Ananta said. She said a very important thing, not about help seeking, but about prevention. The prevention is also, it's just as important, maybe more important, and it isn't necessarily done through national work. It's done through having the right supports locally. So Ananta mentioned it, but I thought I just wanted to emphasize it, because I think that the support for people in the workplace, the support through peer groups, through how managers manage, the way that the employer, the hierarchy of an organisation, a trust, how they support staff, that is a really important part of suicide prevention, about keeping the mental health of staff as good as it can be. So those local preventive measures are just as important as having the right supports available for people when they do seek help. One final comment: people have mentioned that among health staff, it's actually not doctors, but nurses, particularly female nurses, who are most at risk, and care workers too. But there is one other group, and that's paramedics. The figures are very low, and so it's hard to get statistically robust data for paramedics, but the suggestion from even relatively low numbers is that they too could be at higher risk. And why would that be? Well, maybe it's because of, at least to some extent, because of the traumatic work that they is part of their day-to-day responsibility. And if you extend that to how people's responsibilities at the moment, I think it is very important for us to see that we have a workforce who in general is protected against suicide risk, certainly the medical workforce, but we also have people going through quite unusual trauma in their daily work at the moment, and being aware of that traumatized group in the coming months, and the fact that traumatized health staff in other areas have been at higher risk. I think we just need to be conscious of the additional support that people are going to need. It's about help seeking, of course, but it is also about getting prevention right.
Thank you, Louis. So we need to move on to the next subject section of the agenda now, but again, more comments that come through, including suggestions of resources that are out there in Scotland and in other areas, and we will publish those with the webinar or on the website as well afterwards. So I think to link into the next section, which is about the impact but what we know about the impact on BAME communities of COVID-19 in context of suicide prevention. And you talked about trauma there in your last answer, Louis, and I think I was thinking in relation to this next. Hi, sorry everyone, I was my internet dropped in the room I was in. I've had to quickly run to another part of the house to continue this. So the next, I don't know, sorry if you got some way in discussing the next part of the agenda, but the next part of the agenda is about the impact on BAME communities of suicide prevention. I wondered if I could go to Ananta first of all to talk about this. So I've been thinking about trauma at a community level around BAME communities, and particularly in relation to COVID and the impact around COVID on BAME communities that we know is the increased risks and the high number of deaths, but also the trauma that people from particularly the Black community, but also other BAME communities will be feeling, and the re-trauma that they're feeling in the context of what's happening in the world as a result of the death of George Floyd in America over the last week. So, which I guess where I guess some of the same issues are involved. So I wonder if I can go to Ananta first of all, just to have to give a view on that.
Yeah, thanks, Tom. And indeed, a very topical issue, and I think very important for us, all of us working in health and care, to be able to acknowledge the impact of inequalities and racism on mental health and all health outcomes. And I think the first way in which we can address some of these inequalities is about acknowledging them openly and having those supportive, constructive conversations. So I think, and to be, and just to place it in context, the work that I'm doing, with the Royal College and the report that we wrote does not relate specifically to suicide risk or suicide prevention, but I think the principles are important. So we looked at the impact, the disproportionate impact of COVID-19 on staff from Black, Asian and minority ethnic backgrounds. And we know that there is emerging literature, and it is giving us more granular data about within those communities who might be more at risk. So Bangladeshi men, for example, Black men, Black African Caribbean. So I think there is now more data. So we know that males, older males, and those from some of the Black, Asian and minority ethnic backgrounds are more at risk from COVID. And what also seems to be the case, that even after accounting for things like socioeconomic deprivation, underlying health conditions, comorbidities, all the other things that might be confounding factors or, additional variables, even after all that has been taken into account, there seems to be some unexplained or independent risk associated with being from BAME community. So there is, I think, further research needed to understand, at the moment we are talking about association rather than causation, but I think really important to keep in mind about what this disproportionate impact might mean. And, in my previous answer, I alluded to the inequalities being amplified. So I think in terms of risks to BAME staff on their health, on their mental health, physical health, their safety, I think, one of the things that we have to talk about is surveys have shown, surveys from individual organizations, professional organizations like the Royal College, NHS employers, BAME. So the surveys have shown that people from or workers from BAME communities across all backgrounds, doctors, nurses, we've had surveys from the Royal College of Nursing as well. So surveys from across professional bodies have shown that people from BAME backgrounds, professionals, might find it harder to speak up or raise concerns, or when concerns are raised, might find it harder to have them addressed. They might have more difficulties in terms of accessing PPE or being able to have those conversations about working from home or redeployment. So there might be more instances of BAME staff being working in front-facing roles, which might put them more at risk of exposure to COVID-19. So although these are in relation to COVID-19 risks and how it might affect safety and health outcomes, I think the general principles apply to what we're trying to do in the world of suicide prevention, that is in terms of preventing. So firstly, those organizations being proactive in identifying that there is a problem, that certain groups of professionals are more at risk, and that they might that they need to take the first step in helping them to have those conversations, which is taking a stratified approach, a flexible approach about how we understand the various risks. I think it's really important that we don't just depend on a risk assessment tool or a checklist. I mean, there are several in the public domain, several of them aimed at identifying the risks to BAME staff. And I think it's really important that, we realize that it's not the tool which is the most important thing. It's not a checklist or a score that's most important, but it's about the tool being an aid to that kind of a rich conversation, which is supportive, which is meaningful, which is placed in context, and which understands that people work not in a vacuum, but as part of, they live as part of families, teams, communities, so the context and the environment in which they work, the role which they have, these are all equally important factors. So I think what I would say in relation to supporting BAME staff or supporting groups who are more at risk is not just depend on a checklist or a risk assessment tool alone, but create a culture. We in the mental health world know about the importance of psychological safety, creating safe spaces, creating psychologically safe spaces for people being able to open up and talk about their concerns, ask questions, ask for the right protections, which is their right. So I think create that culture, have a stratified, sensible approach to risk identification and prevention, preventative approach, better than waiting till the problem becomes, very high. And I think also if when organizations show that they're taking it seriously, that they're acknowledging, identifying it, naming it, putting it as a risk at the highest level, at board level. So they're identifying it as a core risk for the organization, and that if they get it right for the staff who are most at risk, or the people who are most at risk, they get it right for everybody. And by protecting staff, we are actually protecting patients and sustaining services. So the impact or the consequences of getting it right are huge, for both staff and services. So I think, although it's the data and the report is not about suicide prevention, I think those general principles apply about having that organizational approach and providing, Louis referred to those various ways in which we can improve that psychological safety, and using existing mechanisms, whether it is having those staff networks, for BAME staff, for various other staff who might be in a vulnerable group, whether it is having things like ballot groups, Schwartz rounds, question and answer sessions, direct access to board members, engagement. So a variety of ways, including the technology that we have at our disposal now, a variety of ways in which the senior leadership needs to engage with the staff and support the senior leaders in having those conversations. We need to support the leaders as well. So I would say those are some of the take-home points which can be applied to various things, including suicide prevention for vulnerable groups. Thank you.
Okay, that's fantastic. Thank you, Ananta. And I'll just hand over to Nav, who we have actually got on video now. So Nav, I wonder if you'd be able to to add to that, or to
can you? I can't see that I've been transferred. I have now been transferred. Nice to be on video with you all. It's a really important issue, the BAME issue, and again, it's this concept of a kind of double risk factor load. It's they're more affected by COVID. We saw that from the Public Health England report yesterday, but also there is an intrinsic suicide risk with associated with being from a Black and minority ethnic group. Now, that's quite tricky from a research point of view for two reasons. The first is routine data does not record ethnicity, so we do not have definitive data on suicide rates by ethnic group. And the second thing is that studies that do occur tend to lump many BME Black and minority ethnic groups together. So, for example, we have a catch-all South Asian group in some of the studies. Having said that, some of the older studies based on place of birth suggest that in particular Black Afro-Caribbean men might be at greater risk. A study we did of self-harm suggested that young Black women might be at greater risk of self-harm. In terms of what we do about that, it's some of the kind of more general measures. So it's thinking about discrimination. It's thinking about the role of social inequality in both mental health problems and suicide risk. But it's also encouraging help seeking, reducing stigma, encouraging help seeking. We found in one of our studies that actually people from BME communities who hurt themselves were less likely to repeat. Now, it might be they're just less likely to repeat, or it might be they're less likely to come back to services because the service they received wasn't culturally appropriate. And so that's something we need to be mindful of. And also some of the other kind of associated risk factors as well. So physical health risk factors that we know are associated with suicide, but are also more common in Black and minority ethnic groups. So they're the beginnings of some of what you might want to do to kind of tackle some of this.
Thank you. Thank you, Nav and Ananta. Really fascinating and thoughtful answers there. I'm very struck by the idea that we don't have that the data does not record for suicide routinely record ethnicity, and I wonder if that's something that hopefully may change. I
think Louis was trying to get in there.
Oh, sorry, Louis, did you have a comment on that as well?
Yes, just on the issue of the data, it's been a real gap in the data that we haven't been able to record ethnicity in suicide data at inquest, and even if we did, we haven't really got a satisfactory denominator of ethnicity in the general population that would help us work out rates. But I don't know if you noticed, but just 2 days ago, the NHS announced that it would set up a race and health observatory, which would aim to address some of these issues because they're not unique to mental health and certainly not unique to suicide. And the aim is to answer some of the questions about ethnicity. The COVID crisis, I think, has highlighted, it's played out along the fault lines in society, and one of the main ones is the the ethnicity fault line. And when you see the images on our screen at the moment, it's incredible that we're still watching these things at the moment, these terrible scenes, sort of disgraceful behaviours. And that's also about leadership. It's about the attitudes that are out there in society at the moment and putting them right. So it is about data, but it is about these much bigger social issues as well. I would say that in the future we should have no public database that can't be analysed by ethnicity. That should be a commitment from statistical authorities and from the government.
Thank you. It's really powerful words, and I think everyone would agree with everything you said there. Can we move to the final? We've just got a few minutes left, and I'm sorry, those two subjects were so, I think, important. I think it's okay that we spent time on them, but we now got not much time for the final subject, which was about the changing face of mental health services in COVID. We did talk about this to some extent last time. There was a question earlier on about the dropping referrals, not just to A&E, but also some IAP service and some other services. I wonder whether perhaps now if we could go back to you to comment on the change, anything you know about the changing face of services.
Yeah, I mean, it's a very important point, and I just caught bits of what Louis was saying earlier on. My apologies, but I mean, it's been very, very striking in mental health services, particularly liaison psychiatry services, about the reduction in footfall early on. So, you know, reductions in self-harm, hospital presenting self-harm rates of 40–50%, which actually are identical to a reduction in footfall in emergency departments more generally. So I think that's certainly what's happened, and it's been very interesting to see how, you know, brilliant colleagues have kind of adapted to these very unusual circumstances. So one bit of the response seems to be how services have been rationalised. So really, the focus has been on emergency services, which I think's right. But the other thing I think has been really thinking about the settings in which we provide care, and we talked a little bit last time about remote and video assessments, and colleagues doing brilliant work in that area, and I know, you know, that our own Royal College has got guidance out on that as well. But there's also other things as well. So, for example, in liaison psychiatry services, having urgent mental health assessments taking place in a site a bit removed from the emergency department, that's good for people in mental health crisis. They're not in with the general emergency rooms, and it's also means that services can be a bit more kind of efficiently organised. So I think those have been incredible. And, you know, the comment you hear again and again and again is, you know, changes that would have taken years to implement in the past are being implemented in days or weeks. And I think, you know, one of the challenges going forwards is going to be keeping the best bits of that, because I think, you know, there's been some really, really good practice, and you know, some of the comments I've had from kind of service users are that they like the changes too. You know, in some senses, some services are more responsive and accessible, but that isn't universal, as came up on the web chat last time, and I know that, you know, some people are still finding it hard to access services, but that kind of innovation, that change and that access, I think, has been a really positive thing.
Sorry, I was muted there. Ananta, could you? I just wonder, in your role as medical director, what your view? I'm really sorry. Can I ask you to maybe tell us in about 90 seconds your view of?
Yeah, I mean, I think just picking up from Nav's point, people have adapted very quickly in a very short time scale to a new way of delivering services, increasing access to crises and urgent appointments and 24/7 services. I think for me, the thing that I would also take home is the renewed contract and cooperation between agencies and services across a whole health and care system, which perhaps wasn't happening at the same speed. So what I would say is that apart from the speediness of responses, the collaboration between primary care, secondary care, social care, voluntary care, that's been really helpful at systems level, and I think we should hold on to that so that we can get back to providing the services we need for the future. Thank you.
Thank you, Ananta. Yeah, a really important point and something I've heard certainly over the last month or so. So we are coming to the end of our time. I want to thank the panelists again, so Louis Appleby, Ananta Dave and Nav Kapur. It's been a fascinating discussion. I apologise that I had to drop out of it with internet problems halfway through to come and then come back. I wonder if I can just, and I'd like to thank everyone who's joined and watched the webinar and also asked any questions. As I said, we will be posting more information afterwards, including a recording. I wonder if I could just finish by going to Louis for final word on any of the subjects that we've been talking about today.
Well, I think the final thing to say, there's been an interesting report out today from NHS providers, which is about mental health services, and it's an acknowledgement. They've got their information from the trusts, and that it's an acknowledgement of all the things that Ananta and Nav were talking about, the way that trusts and clinicians have adapted, the things they're doing to address the changing need, changing circumstances. But it also calls for 4 things. It says that the trust will need 4 things in the future. One is protections, so PPE, but also testing. Another is to have help in modelling demand and capacity so that changing requirements for mental health, if there is an increase over time, can be dealt with. Sustainable resources and the ability to develop the workforce in a way that we were already struggling with in mental health before the COVID crisis hit. So those 4 areas are what trusts themselves are looking for, and it sounds like a good blueprint to me. I just want to say thanks to everybody for the work they're doing. Very important. Thanks to the audience for being here.
Right, okay. Well, thank you, everyone. That's the end of the end of our of this webinar. We will hope to do more in the future, and obviously we'll advertise that as widely as we can when we do. Thank you, everyone.
Thank you. Thank you. Bye-bye.